Okay, good evening. Welcome, welcome. This
Good
is
afternoon.
week 6. Hello. Week 6, and that's, of course, module 6. Week 5 items are due. So if you look at week 5, any these medical language laboratory for the nervous system, and of course the quiz, but there should be a discussion, and I'll give you until, for those of you who missed out, I'll give you until later on this evening. So what's going on in week 6? We go down into module 6, and now we're going to look at the urinary system, also known as the renal system. It's urology, and for due next week. And I'm going to put here in the discussion forum the same format that we've been did for the last discussion. Oh, heck, I'll do it right now. And it's create your own exam. So discussion number 6 is create your own 5-item multiple choice quiz based on this week's case studies, and that's renal, in the back of the urinary renal chapter. And I will highlight that. Let's post this now, and I will highlight it at the end of the lecture when we get there. So let us now go to our medical language lab.
Professor, quick question.
Yep.
For the discussion one, that was for any chapter before the midterm, right?
Yeah, the other one from like last week, that's for any chapter.
Okay,
But
cool.
for this week, it's specifically for the renal. But remember, the format for the final exam is not going to look like the midterm anymore. It's going to look more like NCLEX type, which is you have like a little case and then 5 or 6 questions relating to the case. So, but they're medical terminology type questions. And look at the discussions of your other classmates and the comments that I put. Like if I put something like quite comprehensive, looks just like my exam or something like that, that's what you should be modeling your preparations for a final exam in week 10. So let me open up, where is it? Let's open up my Firefox. Put it in here. No. And then let's look for the renal chapter. So I'm going to go right to my ebook. Table of contents. And urinary system renal chapter, which is chapter 7. Okay. So if we look at chapter 7, the first thing that they always talk about are who are the people in, wait a minute, chapter 7 is not what we're looking for. I'm looking for urinary. Go to chapter 7. Thank you. Sorry about that. So chapter 7, urinary system. So who are the people in our neighborhood? That's the Department of Urology and the Department of Nephrology. And when you're looking at the urinary system or anything that that makes urine, urology deals with the ureters, which are these 2 tubes here, urinary bladder, and the urethra. And if it's a fertility problem, then the Department of Urology, that, as we already discussed in a previous lecture, it deals with any fertility issue in the male. Now, if it was female, a female patient can still see a urologist if there's a ureter problem, a bladder problem, or a urethra problem. So they can go see either a urologist or a gynecologist. That's a beautiful both A and B question. But nephrology, they deal with the kidneys. So if you have something like UTI or urinary tract infection, I'm not really that excited. But the problem is typical UTIs like to go up. And a chronic UTI, if unchecked, will become now a kidney problem. And how important are our kidneys? You have an entire department, nephrology, which is dedicated to it. And both nephrology and urology are subspecialties of the Department of Internal Medicine. So after doing 4 or 5 years in internal medicine, then you do about 2-3 years fellowship, and then you take your boards, and then you could be either a urologist, and that there are people who do urinary disorders from the ureters on down, or nephrologist, which deal exclusively with this bad boy or bad girl, whatever your perspective is, right here, okay, which is your kidney. And you got 2 of them. And on top of your kidneys, you use your medical terminology powers from chapter 2. Those are your adrenal glands or adrenal glands, also known as your suprarenal. Ad means on top of, and supra means super or above. So your suprarenal or your adrenal glands are on top of your kidneys. Okay, so let's start off right off the bat. Let's start talking about some combining forms. And remember, combining form, I won't be asking any more questions related to what's the part anymore. We're not going to do that anymore because we're already beyond that. We're going to be talking about how does this word, the whole word, interact in context of an actual communication, which is your cases at the end of the chapter. So when we're looking at cystoscopy, remember scope versus scopy. If I want to do a cystoscopy, I am in the Department of Urology, and I might want to look at a scope of my patient's bladder. Remember scope, cystoscope is the actual device. Cystoscopy is the thing that we schedule. Vesicocele, hernial protrusion or hernia, and all that a hernia is anything that sticks out that shouldn't be sticking out. Everything in your body has a covering. So if it's sticking out of that covering, it's not a good thing. It's open for infection, and also it'll probably present as pain. So a vesicocele is a herniated protrusion of your urinary bladder. So your urinary bladder is here, and if just for whatever reason there's a covering here, which is your peritoneum, if there's a defect in the covering and the urinary bladder sticks out, especially when you pee, it's going to hurt. And it's going to hurt right here in the hypogastric area, or here your pelvic area right here. Meatus is just a fancy word for opening. And the way we pronounce it is just because, remember, this is not English. You don't pronounce it meatus. In Latin, you pronounce all of the, all the letters together. So me, at, us. So it's called your meatus. Us, structure of. Your kidneys, this is a beautiful both A and B question. Al, pertaining to your renal or your kidneys. So if you have a renal dysfunction, it means you have a kidney dysfunction. Al is pertaining to, that means it is a adjective. So renal what? You can't just say the patient has a renal. Renal what? Renal pathology, renal schedule, renal cystoscopy, what? Renal what? That's like saying to somebody, hey, you're wearing a blue. A blue what? Shirt, hat, underwear, where? Nephroma, oma, remember, it's a tumor. Now, before the biopsy, it just means a lump or bump that I found on my kidney, most probably during an x-ray. But until the biopsy tells me that it's cancer, I can't say it's a nephrocarcinoma yet. It's just a nephroma. Pyeloplasty, that's a surgical repair of the renal pelvis. Now, what's the renal pelvis? What's pyelo? So if I had pyelitis, this is your kidney, and the indentation of your kidney is called your hilum. And in this area right here, think of all of this as like a whole bunch of funnels. And this is the main funnel here, which is your renal pelvis, right here, right before it goes into your ureter. Okay, so your kidney filters out all the blood and then creates urine, which is liquid form of all of our nitrogenous waste products. And it's going to go down all these funnels. So there's a funnel here, a funnel here, a funnel here, and it's going to get to this big main funnel, which you can't see here because the renal artery and renal vein are kind of obscuring it. But when if you're in my anatomy and physiology 2 class, or is it 1? I can't remember. We cut up one of these things and you could see the renal pelvis is that area right there. So that's pyeloplasty. So let's say, for example, last time I ordered a pyeloplasty for surgery, I had a patient. He was riding his Kawasaki Ninja motorcycle, and he kind of crashed and rolled around the ground. And he rolled around so hard, he had what is called a torsion injury. So it pulled on this and separated his renal artery, renal vein, and his ureter from the hilum. And that surgery of this area is called pyeloplasty. I also had another patient who had an infection here, and that is called pyelonephritis. Nepher means your kidney. Pyelo is this area of your kidney. So if my patient has pyelitis or pyelonephritis, they're in a lot of trouble because they're going to need pyeloplasty or surgical repair. Uro means urine or urinary tract. So uremia. Emia means blood condition. And if you see this, the dirty blood comes in there through your renal artery and then it gets all filtered out. But what if this filtering system isn't doing very well? And then all the dirty blood ends up in your renal vein, which is not good. And then all that dirty nitrogenous waste that's supposed to be heading its way down towards the toilet is now in your blood vessels. And that's not good. That'll lead to septicemia as well. So uremia is blood condition of excessive urea or other nitrogenous wastes, or waste that has nitrogen in it. And that's not a good thing. And that is also called azotemia. Uremia, azotemia, that means my patient is probably on the verge of kidney or renal failure, and that is a no bueno situation. Urinary, of course, pertaining to urine. Ureter, we already talked about the tube, this tube, ureter, and this thing is exaggerated for the picture. In real life, it is so small that its lumen, or the inside of it, is about the size of, the tip of your pencil, barely a millimeter wide. So it's easy if you have an infection here, or maybe you have some stones or some damage, to get ureterostenosis. Ureterostenosis is the narrowing or stricture of your ureters, which is this. And anyway, you can get stenosis anywhere. You can even get stenosis here, your urethra. If you have a really bad STD like gonorrhea, that'll close this thing up real good. Emia, we already talked about, blood condition, right? Azotemia. So let's look at some other blood conditions since we know a little bit about, about the structure of medical terms. So I could have hyperemia, which is the blood condition of, and hyper means what? Too much. When my patient's hyperemic or has hyperemia, that means they get flush. You get, their face gets all pink and all full of blood. You can have, what's another emia? Hyperglycemia. That's too much. That is blood condition of too much sugar. I could have hypernatremia. Blood condition of too much salt. And you remember salt, if you remember your, if you remember your high school chemistry, Salt is Na plus or sodium. Okay, and it could be also hypo. My patient could be hypoglycemic, blood condition of too little sugar. They could also be hyponatremic, and there's a whole bunch of things. I can even put protein, hyperproteinemia. That means I have too many proteins in my blood. I could have hyperlipidemia. I've have blood condition of too much lipid or fat. You can go on and on and on. And anytime you have hyper, you also have hypo. And also you have this one. You should be normal. Normal is norm, al, pertaining to the rule. So the rule for euglycemia is my fasting blood sugar shouldn't be more than 92 to 103 milligrams per deciliter. If it's too little, I have hypoglycemia. If it's too much, it's hyperglycemia. And either situation is never good. Or I could say my patient is normal glycemic. Okay. Remember, normal just means al, pertaining to the rule. Okay. Okay. You shouldn't have too much sodium, too much protein, too much lipid. You should have just right. You shouldn't have too little either. Pexi we already talked about. Nephropathy. Oh, I'm skipping a whole bunch of them. Why am I wishful thinking? I want to get all the way down here. Iasis is abnormal condition. So abnormal condition of stones is lithiasis. Lith means stone. Dialysis is dia is complete or thorough. I don't like this definition. I'm using a definition of a previous edition of this book. I don't know why they changed it, but I love dia as complete or thorough. So when you're looking at the word dialysis, lysis means breakdown of complete or thorough. And that's what your kidneys are doing. I could have hemodialysis. Complete breakdown of blood completely. And that's what you're doing. Okay. And we'll show you a little bit later peritoneal dialysis. It's dialysis or breakdown of blood completely, but via the covering of your abdomen, which is your peritoneum. And you don't want peritonitis, inflammation or infection of the covering of your abdomen, because there's a lot of arteries and veins in your peritoneum. It leads to sepsis very quickly. Lysis, we already went pathy, disease. So if my patient has a nephropathy, they have a kidney disease. Nephropexy, what am I doing? I am fixating, or I'm like sewing or kind of gluing the kidney in its place. Nephrotosis is when there's one of the kidneys droop down further than where they should. Ptosis, the word ptosis alone is like, drooping of your eyes. Ptosis. Here's a people's like this. This is ptosis, right? And if you have it bilateral, they just look like, they smoke way too much weed or something, right? But this is neurologic, as you can see, and you can see the left is more pronounced than the right. Okay, and droopy eyelids are just ptosis, or your patient could be just tired. Either way. Okay. Lithotripsy, we already talked about. Litho is stone. Tripsy is, I remember the Y. Sometimes it's a surgical procedure, but it also could be a non-surgical procedure that will break down stones. Let's look at urine. Polyuria. Let's look at that, because that's a really important word. Ia, state or condition. Poly, many, and urination. Other words for urination is voiding, is passing, you know, voiding, urination, and micturition. Those are different words that mean the same thing, which is urination. Now, polyuria. Poly is the prefix that means many. My patient could have polyphagia, which is state or condition of too much eating. They could also have uh, um, polydipsia, which is too much drinking. You put all these three polys together, those are the three P's of diabetes mellitus. These are classic signs and symptoms that my patient probably has diabetes or impending or serious prediabetes. They're drinking too much, they're eating too much, and they're urinating too much. And that makes sense. When you're diabetic, it means that your body isn't taking in the sugar in the way it's supposed to, whether your insulin is broken or your insulin receptors are broken. So either way, your body's going to think that you don't have any fuel. So if you don't have any fuel, what are you doing? You're eating a lot. If you eat a lot, you're going to drink a lot, right? Because food have salts and things of that matter. And remember, wherever salt goes, water has to follow. And if I'm drinking too much, what happens? I'm going to pee too much. So those are the three polys or the three P's of diabetes mellitus. And polyuria, so that's excessive urination. Here's the nephron. They're microscopic. They're all here. Let me just, maybe there's a way to expand this. No, there isn't. All along the cortex of your kidney, which is here, you have like about 400 million of these microscopic things. And this is your nephron, also known as your functional unit of the kidney. This is where the blood gets filtered, the dirty blood from your renal artery, right? The red, and then it creates urine and then goes down all these funnels, which is the medulla or medullary portion of your kidney and into the renal pelvis and then into your ureter. And remember, you have two of them, one on the left, one on the right. Nephritis, that's easy. Here's kidney stones. They're, you can see they're located and on the tips of these little funnels here. This is called a minor calyx, and this area here is a major calyx, and then ending up all of that together combine into the renal pelvis. And you can see here how it's going to mess everything up, having kidney stones. And you may be asking yourself, how do I get a stone? Well, those of you who are like myself, who are amateur chefs, those of any of you ever made a like a crumb cake? All you do is mix lard, which is essentially fat, salt, and sugar together. Isn't that what we have in our bodies? And if it's in excessive amounts, what's it going to do? It's going to make stones. And this is kind of not too accurate. The stones are actually sharp, and they're going to cause a lot of damage and even some bleeding. ESWL, or extracorporeal shockwave lithotripsy. Say that 8 times fast. But when you look at it, when you break it down, it's not too hard. Extra means out. Corpo means your body. So pertaining to out of your body, they take shock waves. And what are they doing to the kidney stones? Litho, which is stone. Tripsy is the process of breaking down the stone. Okay. So this is a non-invasive procedure where you have to sit on the table, and then it shoots safe sound waves to break down your kidney stones. We even also use, we scope it, and then on the end of the scope are like these minor explosives, and we can blow them up as well, which is kind of neat. So that's ESWL, also known as extracorporeal shockwave lithotripsy. Hypertension, nephrotic syndrome, suprarenal. Where kind of went over these. Percutaneous nephrostomy. So nephrostomy or nephrostomy, potato. Stomy is the creation of a opening or a mouth. And percutaneous means, per means through, cutaneous means your skin. So we put a tube through your skin that will help empty out the urine if, let's say, the bladder is non-functional or the ureters are also blocked or damaged. You could stick it, and it's just like a colostomy bag, but this is a nephrostomy catheter bag. Okay, and we're putting it through the skin. And we pay very close attention to this because this is infection city right here, just like your colostomy tube. Let's see what else. Cystovesical, urinary meatus, we already went over that. Cystitis, inflammation or infection of your urinary bladder. Let's look at, let's go back. Let's look at all the potential infections. I'm going to take this and let me put it in here so we could see it. So I am insert okay. So let's start with the kidney. I could have nephritis. Inflammation or infection of my kidney. I could also have of my, here, these are my two ureters. So why won't it let me do this? Draw text box. I could have ureteritis. Now here's my urethra. I can have a, oh well, I forgot to do cystitis. Inflammation and infection of the urinary bladder. And then, last but not least, now, do you see how close this is? Urethritis and ureteritis. Remember, your ureters, two of them. Urethra, you only got one of them. Okay? So I could get nephritis. I should have put this bad boy over here. That would have looked better. Whoa. I messed up. What happened? Let's undo. There you go. This should have been here. Okay, so I could, on an exam, we could talk about past medical history of my patient. My patient has a past medical history of a kidney infection. So what was the previous diagnosis? Nephritis. They had a past medical history of infection of the ureters, right? If it was both sides, it's bilateral. If it's one side, it's unilateral. Cystitis, inflammation or infection of the urinary bladder. And last but not least, your urethritis, inflammation or infection of your urethra. Now, an STD or any other infections can lead all to this. And one of the meanest chronic UTIs you can get is E. coli or Escherichia coli. They tend to go all the way up here and then to progressive nephritis. And that's never a good thing. All righty. So that's my little infection. Let's see what other words look good. Oh, remember we talked about seal or a hernia? Now, what's a cystocele and what's a rectocele? Goes, a cystocele is a herniation of your urinary bladder, meaning your urinary bladder is sticking out where it shouldn't. So let's say, for example, here it might prolapse, as you could see here. It's like sticking out and is prolapsing into the vaginal canal here, or it can like droop down this way as well. And that's called a cystocele. Now, a rectocele, if you see, typically, this is a normal rectum, goes straight down, whoop. But now this one's going to push on here, and you can see it's failure of, the pelvic floor to keep all these tubes in place. And sometimes you'll even get prolapse, meaning the rectum will fall out of here, or you can have also prolapse of the vagina, and it could come out here as well. And typically it happens when mommy had way too many babies, because the pelvic floor gets really, really loose after like the 4th or 5th kid. Here's cystoscopy of the urinary bladder. We could scope it, put it all the way down there, and we actually can do biopsies and little mini surgeries as well. And they have now video connections always, because any of these scoping procedures, it's really neat. We can digitize the video and email it directly to the specialist. So the specialist can give you a wet read almost instantaneously. It's pretty neat. My wife and I got scoped, not on the same day, but at Inova, and it was really neat to see a video of it. And it's very easy to have a second opinion, because you have a video with commentary connected to it with the original nephrologist or urologist, and they could easily send it to a specialist, and then they email you back their results, and it's pretty timely too. A lot of places can do it within 5 business days, which is pretty neat. Radiography is a process of what? Recording radio or radiation. The Department of Radiography usually deals with x-rays, but they also can scope people as well. But it is usually the experts at scoping people is gastrointestinal medicine or GI med. They are the best at it. Let's see some other, and of course the microscopic structures, and you don't have to learn this now, but just know that the functional unit of the kidney is called the nephron, Nephron, and that's what this thing is. And it's microscopic, nephron right here. It's microscopic, and its function is it has a whole bunch of functions, but the main function is filter blood, make urine. Urine goes down these this collecting tubule, and then ends up in the renal pelvis. Okay, here's urinalysis or a urine dipstick. Urinalysis is pretty much broken down into 3 parts: physical, chemical, and microscopic. This is the chemical portion of it, and this is like just a quick screening diagnostic. You dip this thing in your urine, wait about a minute or 2, and then match the color to see what your quick results are. Hydronephrosis, abnormal enlargement of the kidney due to hydro, water. Because if there's a stone or any stricture here or stenosis, the urine and the water will start backing up pressure, and then you'll get hydronephrosis. This is no good. That increased pressure does a number on your kidneys. It damages it. This term here, calculi, it's just another word to say stone. Like lith is a stone, calculus is also a stone. This is how I remember calculus. The calculus is a really hard math, like stone. I don't know. Whatever you need to do to remember it, but for whatever reason, 30 years have gone by, and every time I see the word calculus or calculi, plural, right? Many stones. I always think of calculus, the class. Let's see, nocturia. We talked about polyuria. Well, we can talk about nocturia. Well, why am I writing it down? Don't need to write it. Uria, stated condition of urination. Noct means evening. So nocturia could either just mean your nervous personality, or you might have a sleeping disorder, but it also could mean that there could be an underlying infection or disease. And the first thing we look at is any chronic UTI or any history of diabetes within the family. So continence is the ability to retain your urine. So if you're incontinent, that means you're prone or have a disposition to wet yourself. Urologist, polycystic kidney disease. That's a kidney disease that has many cysts, or little bags of pus. So you see these little bumpies, and that's exactly what it looks like. Know your abbreviations. I'm going to go over a couple of them that are relevant. ARF is acute renal failure versus CRF, chronic renal failure. If you look at the term IC, Crohn means time, right? And acute means it happened really fast. So something like chronic renal failure is something like diabetic nephropathy. It takes a long time to develop, but once it develops, it's there for good, and it does a hefty amount of damage. But with acute renal failure, it's something that happened, like that story I stated about that guy riding his Kawasaki Ninja motorcycle, and then his kidneys got ripped out. That's acute renal failure. Chronic renal failure is far worse. Acute renal failure, I could send it to surgery and patch you up. BNO, I never heard of that in my life. BPH is benign prostatic hyperplasia or benign prostatic hypertrophy. That means the area is growing, hyper, too much, and it's the area of your prostate. And where is your prostate, may you ask? Let's look at the male. Prostate is this organ here, right here. It helps develop the fluid that's included in your semen, so that it promotes the survivability and the ability of the sperm to conceive. All right. Hemodialysis, but we use this term a lot. IVP, IVU, intravenous pyelogram. That's when we let's show you. We inject into your veins intravenously, and then, of course, we know that stuff that radioactive marker is going to go into your blood. It's going to go filter your kidneys, and you can see here, this big renal pelvis here, and then you could see it, and you could see here. Hey, what happened here? What happened? Stricture, kidney ureter left. Okay, here's another potential little one, but this one's bad. Okay, and that's an IVP, intravenous pyelogram, or an IVP. IVU is intravenous urogram. We do the same thing for you, but we make you pee it out. Polycystic TURP, transurethral resection of the prostate. That's when we go through my patient's urethra, across, and that's when we move pieces of the prostate, and that's for stuff like BPH, benign prostatic hyperplasia. ESRD is very common, end-stage renal disease. Okay. Azoturia, increase of nitrogenous substance, especially in your urine. That's not good, because you're only supposed to have so many nitrogens or so much ammonia in your urine. Remember, too much is, your body is always about balance. Too much is always too much, is never good. Too little is always never good. So too little nitrogenous waste in your urine, that's not a good sign. Too much nitrogenous waste in your urine, which is azoturia, that's also not a good sign of kidney function. Diuresis or diuretic, that just means increased urine formation. That's why when you take a diuretic pill, also known as a water pill, that's why you pee more. And if you pee more, it should not bottom out, but it should decrease your blood pressure. Enuresis is yet another term for urination, but this is uncontrolled urination or a form of incontinence. Okay. And if you're an older child or even an adult, bedwetting or enuresis could either mean it could be a physical problem or it could be also a mental problem. Hypospadias or hypospadias is when the whole of or your external meatus or of your penis should be at the top, but sometimes it's on the sides, and that's called hypospadias, and that's easy to repair. My nephew had one. Actually, he's my nephew and he's my namesake. They named him after me, Nelson. But I remember his father was complaining like, why does my son pee sideways? And then me and my cousin Girly, we took a look at it, and and she's a nurse, and she was like, check it out. He goes, the urinary meatus was on like the side of this little baby's penis, and that's hypospadias. All they do is close it up, and then they put the hole on the top anyway. It's easy, and we could do that. We could do that early before the child even remembers anything. Nephritis, that's easy. BUN, blood urea nitrogen. Hey, Nelson Hermy, can you close that door? Sorry about that. He's playing video games and I can't hear. So BUN, blood urea nitrogen. Now, if your BUN is increased, that means your kidneys aren't working very much, because remember, we're supposed to kick out all the bad nitrogens. And if I have way too much urea or ammonia or nitrogens or nitrogenous waste, that's not a good thing. Creatinine is a way that we also test kidney function as well. Creatinine is a substance that has a known passage rate through your urinary system. So we measure that. CT is a CT scan or computed tomography. That's the X-ray that has multiple cuts and multiple slices. Let's look at the typical CT scan. CT scan, urology. You can see how we can take multiple cuts at multiple levels, and it'll give us multiple pictures of what's going on. And lo and behold, found a stone. And it's really neat because then we could tell us what level the stone's at. Pyelography, we already talked about, radiographic study of your kidneys, ureter, and bladder. Sometimes we take this X-ray, it's called the KUB. It's an X-ray that highlights your kidney, ureters, and bladder. And that previous picture that I just showed you with the IVP, that's typically what we use. Now, retrograde pyelography. That's when we put a cystoscope into your urinary bladder, and then we flush it out with material that that makes it kind of glow upon a KUB or an X-ray. But with IVP, I put that chemical in, or a version of that chemical, inside your intravenously, inside your bloodstream. But with retrograde pyelography, I put it right directly into your urethra. You could also do ultrasound, which is really neat. VCUG, voiding cystourethropy, and again, it's the same thing. I make you either drink or I put through via your IV radioactive material, and then when we can take multiple X-ray films of you urinating, and it could see the urinary bladder. Here's a catheter, of course, right? And then the little, you inflate this to keep it in there. Also known as an indwelling catheter. Again, this has to be swapped out regularly because, again, point source of infection. Dialysis, hemodialysis we talked about. Now, what's peritoneal dialysis? Your peritoneum is the covering of your abdomen, which is right here. Now, what we do is we put a port or a stoma right here, and we use this material called your dialysate. You take the dialysate and you hang it on a T-bar, and then it drains via gravity into your patient's stomach. Then you put the patient's typically lying down, and then we slosh the patient back and forth to mix all the dialysate inside here. And then, like I forgot the process, 30 or 45 minutes later, you have the patient lie on their side, and then you put the dialysate, the empty bag on the floor, and then it fills up with all the dirty fluid here. And that's another way to get rid of all the extra nitrogenous waste. But it is tedious and it takes a long time, and it has to be done in a pretty sterile environment in the kidney center. And when you do it, you're gloved up, you're masked up, and you're watching for signs and symptoms of any infection, and also you're doing vital signs on a regular basis. I hated doing this duty. It's a lot of tedium, but it's really important because they then analyze this fluid. Now, a stent. What's a stent? A stent is essentially a tube bypass. Just in case there's blockage or there's problem here, we can install a stent. So it's like a tubing that keeps this pathway open so that the patient can urinate. Antibiotics, of course. Anti, against, bio, which is life. So antibiotics only deal with bacteria. You can't give antibiotics for a viral infection. You can't give antibiotics for a fungal infection. If you want a fungal infection, you give the patient antimycotic. If it's a viral, it's antiviral. Antidiuretic, or the ADH, antidiuretic hormone, that's the hormone that tells you don't pee. You don't want to pee when you have ADH in your system because you want to conserve water. Antispasmodic, all of these things have muscles in them. Your bladder is a muscle, and your tubing is surrounded by muscle. So when you get a spasm, it hurts. And that's why you really, when you need to pee, you should pee, because if you don't urinate regularly, all this will start becoming spasmodic and it starts to hurt. You get really bad cramps. We give you supplements, especially for salts like potassium, because if my patient's on a diuretic, many times not only sodium depletion, but there's also potassium depletion as well. And remember, too much of a good thing or too little of a good thing is bad. If you have hyperkalemia, which is too much potassium, or hypokalemia, which is too little potassium, it can easily induce heart pathologies. Actually, we just had a professor last year. I believe he passed away due to hyperkalemia. Now, remember I mentioned cases at the end of every chapter. So if you go at the end of every chapter, or even if you go into the table of contents, it will always go to medical record activities, and then they could give you not only the case, which you're responsible for, which, by the way, now you're responsible for any case of any chapter that we went over, including chapters 3, 4, 5, or the other chapters pre-midterm. But the neat thing that this also does and helps you with making the quizzes for your discussions is they give you all the really important words. And they even can give you a question. Can you easily turn this question into a multiple choice? Yeah, sure. So what prompted the consultation? So another question would be, let's give you a little hint on how. So let's say I'm going to pretend to be you, and I'm going to make a question based on that question that just came out. So essentially, what was the chief complaint? So why did Mr. Jenkins in what's the name of this case? Why did Mr. Jenkins in what am I going to call this? Or if I had the case already, he goes, come to our clinic. And then you could have, right? So he came in with what? Patient 65-year-old black male came in with symptoms of dysuria and urinary frequency. So could I put, right? And of course, on my exam, I always copy the case. Painful, or D, all of the above or none of the above. So of course, right, you look at this case and I go, and I ask yourself, well, he had dysuria and urinary frequency. So the best answer is, of course, painful or difficult urination. And that's what dysuria is. And that's how I could also ask. He has goes, does Mr. Jenkins have a past medical history of cancer? If so, which cancer? Colon cancer. What did they do with his colon? Performed a colectomy. So they removed his colon. Hey! This is what happens when you have to share a basement. Preoperative catheterization. Did we perform it? Nope, it was not possible. Right? Now, who is the consultation? It's with a Dr. Moriarty. Who is the physician who's writing this order is Dr. Augustino. Now you know my life. All right. So I could easily ask, what was the past history? And then I would ask it in a way that forces you to tell me what does it mean. Like, for example, it goes, did we perform, did we perform, it goes, any procedure on his prostate in the past medical history? And you're going to look it up and it says -4 transurethral resection. So they didn't do a TURP, transurethral resection of the prostate, which is TURP, TURP, right? I could ask, true or false? Does Mr. Jenkins have a history of any venereal disease? No, he does not. But he has hemorrhoids. He had a bilateral inguinal hernia repair. I could ask, past medical history. Did we repair the left side, right side, both, or neither? It's bilateral, so it's what? Both. What kind of blood picture does Mr. Jenkins have? Does he have hypercholesterolemia, hypocholesterolemia, or normal cholesterolemia? Or D, all of the above? He had hyper. He also had retinal surgery, meaning he had surgery on his eye. Geez, how many things? Well, he is 65, so he has a lot of things. Spontaneous pneumothorax. Jeez. Right? And also, oh my God. See, this is my thing. He's African American. How does he have basal cell carcinoma? BCC, its predisposition is light-skinned, typically Caucasian, right? But, you know, it could be that rare case because maybe he has a job where he's in the sun too much. And that's where you get BCC a lot. But if you're a person of color, you should be, there's some protection from UV radiation. But still, something to think about. But I was like, first time I read this case, I'm like, huh? With all these other problems, seem random. Physical examination was performed, normal cephalic. That means there was nothing wrong with his skull. EENT is within normal limits. Neck, no nodules, no bruit over carotids. Another word they will use for neck is the word supple, because I want to feel around his neck area and see if there's any stiffness, so it should be soft. Bruit is the sound that it's like a rumbling, and especially in the anterior triangle of a more older person's neck, especially if they have a history of high cholesterol or hypertension. Over the carotid arteries, you might feel a little rumbling, and that rumbling is called a bruit. That's how you pronounce this word. Not bruits, but bruit. Clear chest is clear to auscultation and percussion. That means I went on the stethoscope and I didn't hear anything. I percussed his chest. I didn't feel anything. He had normal heart sounds, no murmurs. Abdomen was soft, non-tender, no palpable mass, but his stomach was distended. Genitalia normal. Rectal examination revealed he also has BPH. And again, BPH doesn't happen typically in African American males 65 years of age. BPH typically happens with Caucasian males with or without a history of cancer, ages 45 to 65. So assessment or the diagnosis: mild to moderate BPH, status post or S/P, colon resection for carcinoma of the colon. S/P or status post, that means it happens in the past. And typically, if I write SP or status post, I typically put the year behind it. And what's our plan? We want to admit the surgery for a colectomy. Why? I just figured that out. Didn't he have a colectomy? Aren't we more concerned of his BPH? But I could also ask that. What's our plan? What are we going to do? And according to this, that's our plan. So you could see here, it's just a short case, but there's so many things I could ask you, and I could ask you via some of these very common common terms, right? And I could ask, what abnormality did urology find? A, B, C, D. Did the patient have any previous surgery? A, B, C, D. Goes what was the exact location of the person's hernia? Patient's hernia, A, B, C, or D. It goes, and again, another past medical history, A, B, C, D. And that's how you're going to look at doing this week's quiz. And I'm only asking for 5 questions. And the questions should have 4, like at least 4 A, B, C, D choices, and they should relate directly to the case. So for those of you who copied and pasted the case and then put like the 5 questions underneath, bravo. It's exactly how your final will go down. And as always, come week 8, week 9, I will give you last term's final so you know exactly how it's going to go down. Overall, you guys did wonderfully as expected on your midterms, right? And take a good look at at your wrong answers. Even though you only got 3 or 4 wrong, there is always a pattern in your answer behavior. And when you're preparing for things like your T's, MCAT, or NCLEX, you're always looking into your exam behavior on what kind of archetypes or what kind of exam question that always trip you up. So that leaves, you can also do this one as well, or but my thing is pick one, either this one or the one before it, and then make your 5 questions. But you could see here, we could do the same things as well. And also, if you want examples or samples of previous cases from previous lectures that we didn't go over the case, I could easily get you some examples that other students have done, or a quiz that I used to do, because instead of these discussions, we used to have daily quizzes, but this is on the ground and you already have, I mean, this is more like a hybrid online. And you can see here, there's some really neat things, and I'm going to leave this up to you because this part right here, very, very interesting. Cholecystectomy, cholecystolithiasis, and cholecystolithotomy, and cholelithiasis. These are very, very similar. And if you look at your gastrointestinal chapter, that'll be helpful. Hint, hint, I have 1 or 2 questions that mess with these words, and students almost invariably get them wrong because they look like 25-cent words and they don't break them down as much as they should have. So with that being said, now we can open up the floor for questions. I could now stop the recording.